Technology Safety, Current Issues and Advances in the Science Seminar. Our speaker today is Dr. Elizabeth Borycki. Dr. Borycki is a professor in the School of Health Information Science at the University of Victoria, British Columbia, Canada. She currently leads the Global Laboratory for Digital Health Innovation at the school. Since taking up her position at the school, she has led a number of curriculum and research advancements in the field of health informatics nationally and internationally in the area of safety. Prior to joining the University of Victoria, Dr. Borycki spent over 15 years working in healthcare in varying nursing, clinical, and health information technology roles. Dr. Borycki has published over 200 articles, 40 book chapters, and 10 edited books. The focus of her research and publications has been in the areas of human factors, health technology safety, virtual care, clinical informatics, and systems implementation. Dr. Borycki has served as academic representative for Canada for Digital Health Canada, formerly Canada's Health Informatics Association, from 2007 to 2013. Vice President representing North America on the Board of Directors for the International Medical Informatics Association, IMIA, from 2010 to 2013, and Vice President Special Projects from 2016 to 2019. She founded the International Medical Informatics Association Working Group focusing on health informatics for patient safety, and she was the Scientific Program Committee Co-Chair for MedInfo 2017, one of the largest health informatics conferences globally. Dr. Borycki was voted one of the top 10 women in digital health by Digital Health Canada in 2018 and the top 100 health sciences informatics professionals globally by EMEA in 2017. Dr. Borycki is a fellow of the Canadian Academy Health Sciences Informatics, American Medical Informatics Association, and International Academy of Health Sciences Informatics of EMEA. Elizabeth received her PhD from the Department of Health Policy, Management and Evaluation at the University of Toronto, a Master of Nursing from the University of Manitoba, and an Honours Bachelor of Science in Nursing from Lakehead University. Please join me in welcoming Dr. Borycki as a speaker for today.
Hi, everyone, and Valentina, thank you for that lovely introduction. Very, very thorough. And Andrea, thank you so much for organizing the video, as well as thank you, Dr. Claudia Live, for giving me this opportunity to do a talk. I'm looking forward to this today. So today I'm going to talk about health technology safety. Current issues and advances in the science. This is an area of research that I've been involved in for quite some time, actually dating back to 2005. So it's a bit of an area of interest to me, and I enjoy looking at how we can actually improve the safety of software and devices. But before we begin, I'd like to do a territorial acknowledgement. So today we acknowledge and respect the Lekwungen peoples on whose traditional territory this research was conducted, and the Songhees, Esquamut, and Wisanic peoples on whose historical relationships with the land continue until this day. Of course, for those of you who don't know, this is the School of Health Information Science seminar series. And we are actually celebrating over 40 years of excellence in health informatics education. And I always like to think of health informatics as the profession of digital health. And certainly Digital Health Canada thinks we are, so which is very nice. And we've done some amazing contributions as a group in terms of digitizing and modernizing healthcare. So today I'm just going to discuss some of the current issues and advances in the science of addressing health technology safety issues. We're also going to learn a little bit about how healthcare organizations can manage these types of incidents, as well as look at some of the toolkits of techniques developed and used to investigate, understand, and prevent safety events here at the School of Health Information Science. So before I delve too deeply into this, I think we should really look at safety and the context of safety in terms of its historic background when we look at technology and how it's been designed, developed, implemented, and used in healthcare organizations for healthcare reasons. So we know that technology is fundamental to providing healthcare, and we know that different types of technologies emerge over time. So, for example, more recently we've had a lot of virtual care technologies that have become prevalent in response to COVID and the need to safely monitor individuals without exposing them to the disease. So we've had a huge growth in, for example, mobile health applications, sensing devices, and even remote monitoring. But prior to that, we also had a lot of work that was done in terms of creating electronic health records, integrating those records, as well as developing other types of software and devices that support healthcare, such as integrating IV pumps or even smart beds with the EHR. So now we know that large amounts of data is being collected, and then as a result, we've also seen, a lot of data being used to inform decision making, and we also know that healthcare has become incredibly complex as a result of introducing these technologies, and so we need integrative and holistic approaches towards looking at the design, programming, implementation, and evaluation of systems. And we also need to look at this in terms of safety. So as we know, as we introduce new and different types of technologies, we're actually introducing new processes, and those technologies are automating those processes or supporting those processes. And as a result, we need to consider what the implications of that is. So I got inspired in terms of this research from a learning health systems approach. Early in my graduate studies, which was back in the early 2000s, I got exposed to some really interesting literature on organizational learning. And one of the things that was identified in this literature is that we have not only physical bricks and mortar structures, but we also have digital structures that are part of the organization and the community. So now when we look at a hospital, we don't necessarily just know that there's technologies that are in the hospital that are used to support care. We also know that the hospital may have remote monitoring technologies, or in the community, we might have an individual who purchases different types of technologies to support their health and healthcare. So what is important to remember here is that digital structure needs to be implemented, it needs to be configured, and it needs to be placed in the context, right? So it supports those organizational processes and outcomes. And if you look at this particular cycle, it's very consistent with the quality improvement literature, which we talk about looking at processes, learning from those processes in terms of the types of issues that are present, and then improving upon those processes. Well, in this particular case, we are also improving upon the digital structures that are present in organizations, and that processes involved in creating those digital structures. So it's really important to think of this in terms of a learning health system and learning approaches. So a little bit of background. I always think it's good to have a little bit of background about the past. If you look back into the literature, in the late 1990s, there was a report that was published. It was called "To Err is Human" by the Institute of Medicine. And this report had significant influence on healthcare internationally. So this is at a period of time where perhaps not the rate of the amount of digitization in healthcare was very low, and it was low internationally. And one of the things that the report identified in the US is that approximately 98,000 people die due to medical errors annually. And in order to address that, one of the things that the report identified is it identified a group of very important studies that were able to demonstrate how technologies could reduce errors. And that's something that's very important, because this report set out the policy for the next several years in terms of going out and modernizing the healthcare systems that we have in order to reduce medical error rates. So the report, for example, recommended that we look at prescribing systems, because they could actually address the issues around legibility of the medication information, and in terms of automating processes, so that you could prevent the introduction of errors as information is passed from the physician who may be working in the hospital and at a unit there, and sending and prescribing medications and sending that information to pharmacy, and that information coming back. So all these points that historically would have introduced a new opportunity for an error were now being automated, so we actually could reduce the likelihood of an error occurring. So the policy recommendations came out, and this particular report, because it was done by the Institute of Medicine, had huge ramifications internationally. We started to see the modernization of healthcare in many countries in order to reduce error rates. Of note, medical error still remains quite high. This is a publication from 2016. And when you start to think about it, you kind of go, why is medical error still remaining high, even though we've automated and improved a lot of our processes using technology? So going back a little bit, so in 2004, so we had this period where we had a lot of automation and modernization of the healthcare system. And in 2004, 2005, we started to see the first publications that identified that not only could you use technologies to improve safety of processes in healthcare, but you could also introduce or facilitate other types of errors. So what happens is then you have this inadvertent introduction of errors that occurs as a result of introducing new processes in different types of contexts and environments that are used for healthcare. And as a result, we now know, and this is several years later, that errors can have their origins in health information systems and technologies also. So what is a technology-induced error? So the first thing that we did here at the University of Victoria, because we were among the first groups of people internationally to be able to identify this particular phenomenon, is we defined it. So, and it's really important to recognize the definition. The definition, when we defined it at the time, we used terms that were recognizable to not only the technology community, but also the healthcare community. And as a result, when you describe or discuss technology-induced errors, both communities understand what they are, and they also can start looking at what types of solutions are out there for identifying them, for addressing them. So what is a technology-induced error? It's an error that results from the design and development of a technology. It's implementation and customization. It can arise from interactions between the operation of a technology and new work processes. And it can also arise from things such as the technology's use, its maintenance, as well as there is also some research now that has identified that you can have errors arise from interfacing two different types of technology. So for example, a medical device and an electronic medical record, or other technologies such as EMRs communicating with EHRs that are found in hospitals. So what are some examples? Some of you may have seen some of these examples. Oftentimes they're found in the user interface. So for example, differing features and functions could lead to particular types of errors. So there could be errors such as medication discontinuation errors that are result from the user interface features and functions. You could have a user interface auto-populate fields with default information. You could have a health professional accidentally document on the wrong patient record because it's difficult to determine or to see the difference between different records that are open at the same time. And as a result, you could enter the wrong information into the wrong record. We know that fragmenting of patient information also causes issues with looking at information and processing it from a clinician perspective. We know that layout and organization of information actually affects diagnostic accuracy. And again, this can be motivated by the user interface. We also know that health professionals can sometimes become screen-driven as a result of the way the technology is organized. And that could actually lead to a suboptimal clinical practice. It may influence reasoning and as a result lead to a diagnostic error. And we also know that you could have things such as the wrong information being presented in the system, information being missed because it's too difficult to process or identify because of the way that it's structured. And as a result, you could have a technology-induced error. So what we know is that these types of errors are complex. They're not simple. In fact, I like to use the metaphor of a tree where you have an error that has specific roots. And eventually what happens is that you have an issue that occurs. And errors we know are actually essentially an iceberg. Where you see the top of the iceberg, you can see what types of errors are occurring, but there may be others that are taking place in the background. And we're going to increasingly see this as we have more technologies interface together in terms of providing care. And again, complexity is a big issue. So we have to spend more time trying to understand where these types of errors occur and also identifying strategies or solutions for addressing them. So on this journey of looking at errors, I think it's important to first take a look at some of the models and frameworks that are out there. We have quite a few of them. I think some of the early models and frameworks were inspired by some of the work that was done by James Reason, where this idea that you could have different types of things that are present to prevent an error from occurring. So, for example, you could have a policy, you could have redundancies that are present. But if you have all the right events match up together, you could have an error that actually shoots through all the different things that might prevent it from occurring, and then you have that error occur. When you look at the quality improvement literature, what's really interesting, and there's some work that was done by Kavanaugh, is that Kavanaugh identifies that 90% of errors actually have their origins in the actual system of care. And that includes the technologies that are part of that system of care. And 10% of the time, it's actually the individual who is the source of the error. And that's really important, because what that says is that we need to look at errors that we see individuals comment about or submit incident reports about. And we need to understand what things actually led to that particular error. There needs to be a deeper dive in terms of looking at what's happening in order to be able to solve these system-related issues. And if we think about reason, what that might mean is introducing something that prevents that error from perpetuating through a system. So one of the things that we did in health informatics here at the school is we also went through trying to understand where potential errors could come from. So if we have the individual down here who is responsible for that error 10% of the time when they're using the technology, there could be other types of contributing factors. So for example, if you are a government organization and you change a particular policy and that policy isn't reflected in the electronic health record that the health professional is using, then that might actually lead to an error. And that goes for legislation also. We know that, for example, technologies, specifically electronic health records, we're going to use that example, are built on model organizations. So we have model procedures in that organization, we have model workflows in that organization, we have model terminologies. And that is actually, that information is gathered during the requirements gathering process when we're developing software, for example. And if those model organizational policies, workflows, and terminologies that are embedded in the software technology differ from the organization that is taking on that new technology. So they're adopting it because they've identified that this is something they want to use. Then you could introduce errors because there's a lack of fit between what's happening in terms of the model organization and what is actually taking place in the local organization. So you could have an error. As a vendor organization, vendors are responsible for requirements gathering. They're responsible for design, programming, and software testing. So if any of these activities are perhaps there's some issues with them. So for example, the requirements gathering, there may not be a fulsome requirements gathering or something was missed, then you could introduce an error. Similarly, if you create a design that is not fully tested, there may be a safety issue that emerges. There is research, for example, around coding errors actually leading to errors in the clinical setting, as well as errors arising when software isn't fully tested or the testing didn't account for specific things that may be present in the environment of the adopting organization. Then we have to consider the local organization itself. This is the organization that's adopting that technology. They have their own specific workflows. They might engage in configuration of the user interface design to meet their local environment. They might use differing terminologies. They might approach testing in a very different way. And as a result, you may have the case where that organization is very different from the model organization, and then an error occurs. And so, and of course, you know, because we're human, we also do have errors occurring. So you can see how there's a number of different places where you could have these types of issues or errors introduced. So when we think about models and frameworks, one of the things that we looked at is not only our own or developing our own models or frameworks to reason about different types of errors and how one might want to solve them or identify their root causes or origins. We also looked at the literature, and it's kind of interesting. When you look at the literature involving different types of frameworks and models for looking at safety, it actually is kind of bubbles out into 3 different areas. Many of the models actually have their origins in other disciplines. So for example, there are models that have their origins in the human factors area. So we see industrial engineering models that have been borrowed and looked at and adapted for the health informatics setting. There are models that are pulled in from the organizational behavior and social technical setting. These models have a tendency to look at the interactions between individuals and the technology and the environment, as well as adoption processes. And again, they've been customized for the typical health informatics settings. So, you know, hospitals, physician offices where technology is used, and even home care and home settings. And last but not least, there are models that are borrowed from the software engineering literature around testing and design, and they have been brought into health informatics, and they have been modified and in some cases adapted and made different to meet the local issues with digitizing healthcare. So we've got some models that we can reason about errors to find out how they occur. We understand that they come from differing disciplines, and these differing disciplines essentially provide contributions in their own way. But we also know that the models themselves have been adapted to support the reasoning of health informaticians and other professionals who work in the digital health area specific to healthcare. So one of the things that's really important about this process is going beyond models is we also need to understand what kinds of methods can be used for addressing technology-induced errors. So when you look at methods actually can take 3 different forms. Initial work in this area looked at the application and use of qualitative methods, quantitative methods, and then mixed methods, which borrowed from both the qualitative and quantitative approach. Qualitative methods were really effective in terms of describing the problem and understanding how the error occurs. Quantitative methods, on the other hand, are excellent for looking at the frequency of the problem. And of course, mixed methods, I think, are still probably the best way of looking at these types of errors, because you get some information around frequency of their occurrence, as well as some information about what exactly happened. So it kind of is a benefit of both worlds. So good from that perspective. But beyond that, if you start looking at different types of methods, you need to first understand what methods could be applied in this area. So that was some research then work that we did here in terms of identifying what types of methods could be applied to address this particular type of issue, and then when could they be applied. So we developed a continuum of methods that have been used to diagnose technology-induced error, and they fall into 3 different areas. So some errors can be captured before a system is implemented. This is really important to remember and to note, because we know if you look at the software engineering literature, the later in the process of actually going through the design, development, implementation, and maintenance of a technology, the more expensive it is to actually fix a particular type of error. So you're better off fixing it before the system's implemented. It also addresses the whole issue of having to not retrain health professionals, because you're catching the error before it has occurred, so you don't have to train the health professionals about a potential issue that they might encounter, right? And this is also the case with consumers who might be using technologies, right? We want to kind of capture it before it happens. Of course, you can also look at technology as going through a specific type of implementation period. So oftentimes technologies are implemented, and it takes about anywhere from 1 to 3 months for there to be sort of a settling in period in terms of using the technology. And that's a really important period, because at that point in time, everyone is new to the system, and they may encounter different types of issues that may affect safety. So there have been a group of approaches that have been developed that specifically deal with that. And it's really interesting, because those approaches, most of them, at least ethnography and rapid assessment of clinical systems, were developed at Oregon Health Sciences University by a researcher by the name of Joan Ash. And we're very close in terms of location, as well as we have done some work in terms of collaborating in the past. So, and then last but not least, we have to look at errors in terms of those types of errors that occur after a system's been implemented, and we need to understand where they come from, how they occurred, how they were propagated through the technologies, and then conduct essentially a root cause analysis to prevent them from occurring again. So we have to build in some kind of mitigation so that the error doesn't shoot through that particular set of technologies. So again, very important from that perspective. So what can we say? We can address errors and use different approaches before a system's implemented. We can look at errors after a system's implemented in that initial period where health professionals are using that technology, and that's a fantastic way of identifying those issues and then pruning them out. And then last but not least, we can also look at errors after they've occurred in the mature system that's been functioning for a while, and we can continue to remove potential and actual safety issues as time goes on. And again, this is nothing new. This is the way we have to think about things from a technology perspective, in that in as much as we are improving the quality of healthcare, we also have to look at improving the quality of the processes and the technologies that are used to support healthcare. So another area that we actually got into was this idea of looking at evidence-based heuristics for health information system safety. This actually was a project that was done with one of my former students, Chris Carvello. And it was really a great little project, because what we did is we looked at the evidence-based literature and we identified occasions in the published literature where there was a relationship between a particular, for example, user interface issue or workflow issue and an error. And what we did is we developed heuristics. Now, in the process of developing them, we identified that they actually flowed into 4 different areas. So one of the areas being the actual content of the system, another area being workflow issues that emerged when using the system, as well as functional issues with the actual system itself, so how it functioned, and then also whether or not the system had specific safeguards that were recommended in the literature and could prevent errors. And here's a list of the different heuristics that came from that research work. And we've actually taken these heuristics and used them to evaluate a system as part of a procurement cycle. So you could look at a technology and use the heuristics to look at whether or not that's a safe technology before it's implemented. And that could inform how you might select a particular technology for implementation, or it could influence things such as how you go about testing the technology if you have chosen to buy it, and configuring it, as well as looking at how it fits into the workflow and processes within a given organization. So there's a lot of advantages to using this particular approach before a system is implemented, as I showed earlier. Another thing that we have found that has really worked well in terms of technology-induced errors is this idea that usability actually is really important. In fact, one of our first publications in this particular area showed how specific user interface features and functions were directly related to technology-induced errors. And the interesting thing about this particular publication, which was done in 2005, is that what it started to point to that there was a relationship between what you designed and what kinds of workflows that design had, and then what implications it had for errors. And we did this research in a simulated environment. And as a result, it was a good way to actually engage the healthcare professionals in the process of asking about what they were thinking of or what they thought they were doing when the error occurred. And it was also interesting from the perspective that some clinicians were able to identify when an error occurred, and others actually missed it. And that's the part where you start to understand how the clinician thought they did the right thing. In some cases, they recognized the technology did something that changed what they were doing and caught it. In other cases, they didn't. So again, it gets back to this idea that we need to really look at technologies and refine them and improve them over time as we work with them in the healthcare setting. So again, usability testing, it's a fantastic approach for identifying these types of issues. We've used the approach here and developed out some of the coding schemes and the methods to make it easy and reasonable to use in clinical settings. And it can be used before a system is implemented, after it's been implemented, if you're trying to figure out what's happening in that early implementation period after, the first 3 months. And then also later on, if you have to conduct more deeper understandings of what's actually happening with the technology and how it might be introducing new types of errors inadvertently. In addition to that, to sort of heighten the level of complexity, we know that that individual clinicians, such as so back in this is an example, we have an individual interacting with the system, can have errors occur. But we also know that you might have teams of individuals who are working in a particular setting, and as a result, there might be different types of technologies that are being used, and as a result, inadvertently, errors might be introduced as a result of teamwork or how those different technologies are used. So one of the things that we've done is we've looked at this idea of having a clinical simulation where you could actually see how the technology is performed in supporting the health professionals. And this was an actual offshoot from the early work that was done around evidence-based heuristics, one of the things that we identified in the work around the evidence-based heuristics is that you could step through a user interface, you could look at whether or not it was safe or wasn't safe, but the problem is it wasn't actually a dynamic event. So there's a lot of dynamism in a clinical environment. There's a lot of activity that's taking place, and stepping through a user interface would identify some of the issues, but may not actually take into account things that are being physically done in the environment. So for example, interactions with a barcode scanner when you're giving a patient medications. So that's a good example of that kind of bringing out that dynamism that happens, and understanding that, you know, beyond the user interface, what does it do to the individual who's interacting with other technologies in order to complete a particular activity. And so one of the things that was really quite nice is we had a person by the name of Sanne Jensen who came here to visit us, and she actually took on some of this research work and did some work around introducing these types of evaluation approaches in a simulated environment in more in environments such as the OR. So you can see down here below, they're actually testing out a new system to see how well it supports an OR team's work. That's actually not a real person. This is a simulation. So this is a mannequin, much like you have the mannequin in the upper left part of the screen. And also in the context in the upper right part of the screen of clinicians interacting with artificial patients or actors playing patients. So you can see how the technology and the clinician interact and what kinds of things emerge in terms of potential issues. And then beyond that, one has to start looking at, you know, how simulations can actually provide unique information in terms of understanding the potential effects of a technology on work. So and real world settings. So one of the studies that we also undertook is we took this idea of linking the data from the clinical simulations and then adding that to computer-based simulations and then marrying them together. And in the process of marrying them together, we not only see how, let's say, a technology performs in a typical clinical simulation, but we can also see what would happen if that technology was implemented in a healthcare setting and allowed to just do what it was doing. And the interesting thing about this is that I found that organizational leaders have found this research very interesting and these methods interesting, and that they're oftentimes confronted with situations where they have to make decisions about what to look at in terms of software configuration, what kinds of things might need to be fixed. And they're trying to make a decision, and the simulations actually allow them to identify those things that would have the most impact, as well as occur most frequently, and how they would go about making that decision involves selecting those things that are most concerned. And that simulation supports that decision making. And here's an example. One of the benefits of having a simulation is you could look at just leaving, for example, a particular user interface the way it is and have the errors continue on. Or you could look at saying, well, you know, if we fix that part of the technology, so we change the configuration or we alter the user interface, we could see the impacts of it, of those alterations on safety issues. Like, for example, reducing the number of incidents or reports. So which brings us to incident reporting. I think this is a very important activity for healthcare professionals. Healthcare professionals oftentimes encounter events, and then they're actually asked to report on those events. And this is a commitment to improving the quality and safety of systems overall. And when you look at incident reporting systems, they're not just about technologies, but they're about a wide range of different activities that take place in a healthcare organization and attempts to try and improve the quality and safety of those processes. So we know that when we look at technology and health technologies, that there's an expectation that the number of errors might increase. And the reason why is that we're now starting to see more and more technologies integrated into our healthcare system. So it stands to bear that the additional complexity is actually going to lead to more safety issues, because you have to deal with each of these technologies and as integrated units in order to be able to address safety. So to try and speed that process up a little bit, this is some research that we worked on here and with one of our students, Amir Farghali. And what we did is we looked at how you might integrate differing types of human patterns of qualitative coding of text-based incident reports with machine learning. And we just tried this as a little bit of a pilot study. So what we did is we identified 2 years of safety incident data from the MOD FDA database. And what we did is we went through the database and reduced the number of incident reports by looking at electronic health record vendors. And then what we did is we looked at the individual incident reports with the definition of a technology-induced error at our sides, trying to see whether or not the incident report reflected the actual definition of a technology-induced error. And then after that, we actually reduced the number of incident reports down to a set number. And we coded those incident reports using a taxonomy that we're actually building and from the literature right now, which we have a publication coming out on that soon. And that's something that I'm doing with Evangeline Wagner, and as well as Kat Goslin. So then what we did is we used that taxonomy to code the data. And then what we did is once we coded some of the data, then we used in vivo's machine learning algorithm to actually continue coding the data. And we found that it actually worked quite well successfully. So we started off with over 2 million reports. We had ended up 184 that were basically from the top vendors. We excluded about 156 of the reports and came and actually reduced it down to 28. And we used this particular taxonomy to code the data, and then we actually tested it to see whether or not it continued to code effectively past a certain number of reports. And so one of the things that we found was there were a number of different factors that led to technology-induced errors occurring. So for example, there was software contributed to it. Interoperability issues were an issue. Alerting became an issue. The interaction between the individual and their work environment, so the socio workflow piece. There were programming problems. We also identified other types of issues that were a concern. And of note, one of the things that kind of came out is that a lot of these activities involve differing acts around medications. But that's not all of them. So in addition to that, one of the things that we also did is we looked at the incident reports in terms of complexity. And this was kind of an interesting exercise, because when we started looking at the incident reports, we found that there were a number of different factors that contributed to a technology-induced error occurring. And it was seldom that it was a few factors. It was actually quite a few factors that contributed. In fact, it was kind of interesting. Most of the reports actually had at least 5 different things that actually contributed to this particular error, which starts to suggest that we're in a situation now with all the technologies that we're using and the complexity of these technologies that we need to start looking things a little bit at these things a little bit more differently. In fact, it's when I was looking at some of the literature in and around this, if you look at early reports of incidents involving technology and safety, a lot of them were quite simple to address. A lot easier to just, make a change in the system, for example, reconfigure it, or perhaps change some of the features and functions to sort of improve the workflow. But today, what we're starting to see is there's a lot of different things that are going on with systems. So in addition to the technology, so let's say it's the electronic health record, you also have things such as devices that are interfaced with that record, and that record communicates with several different systems So you start to see how the cluster of things together starts to make things a lot more complex, and it also places a greater burden on the person who might be looking at these systems and are trying to identify where errors can potentially come from. So, you know, when you start to think about it, it requires a certain kind of knowledge and background. And this is consistent with some of the work that was put out by Borycki and colleagues, where you're now starting to see teams are not only consisting of health professionals, so you might have physicians that are involved in looking at the error, nurses, quality improvement professionals. You might also have health informatics professionals who have human factors backgrounds as well as understand the systems that are involved. You also have individuals who are experienced in, for example, looking at systems and their interfacing, and that might also contribute to that. So in addition to that, in order to try and look at these types of errors, we've looked at complexity, we've looked at different methods, we looked at different incident reports. We also wanted to find out whether or not safety was actually influenced by vendor. And this is kind of an interesting little study, because what we found was that a lot of these incidents actually are common across different types of vendors. And that actually makes sense, because now we're starting to see a science behind this, and that there are things that are issues, and they're not unique to one particular vendor. And what that says is that we need to start identifying what these particular issues are and finding solutions for them, because they can be applied in varying different technologies and varying different organizations. And that starts to become exceptionally important, because we're not creating one-off solutions here or there or everywhere. We're starting to create clusters of solutions for specific issues. So what we did is we looked at different types of errors that occurred in the incident reports. And then we also looked at what specific types of errors occurred, and we found that they were common. And again, very important, because you want to develop a safety science, you want to develop something that many individuals can use, and that can be used today in regards to some software systems, and in the future to inform software design, development, implementation, evaluation, and even addressing issues into the future, because they're similar. So there's more value from the perspective that you can start to see that that safety is something that everyone should be involved in. So last but not least, in addition to looking at publicly available FDA reports, another thing that we did is we looked at recall and safety reports, just to see if there are any differences between the incident reports and the recall and safety reports. Now, what's kind of interesting is that there are quite a few reports that are published every year, and oftentimes they look at, for example, differing aspects of technologies that are used by individuals or even in healthcare organizations. And there's a number of reasons for them. Now, what's kind of interesting about these types of reports is that they essentially look at things such as software bugs, software updates, and other causes. So important from that perspective. So you can see that there are a number of different types of issues that specifically deal with the technology. And many of these types of issues actually have been also reported in the general health informatics literature when you look at safety. And what that says to me is that the incident reports and the fact that we have these recalls and these safety reports suggests that there is reporting that's taking place. We have some new things that are emerging over time in the incident reports, and they're also being looked at in terms of recall. But there is work that needs to be done in between in order to be able to identify these particular issues and address them and identify solutions.
The other thing that's important that we started to understand when we looked at the data is it's really important. So, in conclusion.
So, from an organizational perspective, We also have to look at risk management. So this is sort of the components that are very, very important. So if we look at risk management, there are different ways to look at risk. One of the things that you can do is you can look at it in terms of taking a group of methods and then using those methods in order to be able to prune off errors over time. So for example, you might apply evidence-based heuristics, and you would correct the defects that emerge or identified in that process. You might do some usability testing, and again, you might correct the defects that are present. In addition to that, you might do some clinical simulations to see how the technology works in a given environment or setting and the way it's been configured, and you might remove those particular defects that come up. And then you might also do some naturalistic testing. So, you know, you've implemented and now you want to find out what's going on. And then you might try to address issues that are popping up as the clinicians are identifying them and then you're observing them. So over time, what happens is that you're essentially taking that tree and pruning it and making sure that you're pruning off all the safety issues and creating a safer system overall. So, and again, that's that part where he's starting to look at developing a testing plan. So, you know, in as much as we looked at methods and where they might insert, and then we tested to see whether these methods actually worked, and identifying these types of issues. Now you can take that information and then you can create a testing plan for your particular organization. In addition to that, you also, in the process of educating health professionals and working from a health informatics professional perspective, you're also going to educate and let everyone know what types of potential issues may occur, how to report them, and then how to work as part of the process of identifying solutions. Because there's a lot of opportunities to work together and identify potential risks, and again, prune them off over time. In addition to that, what organizations can do too is they can start looking at their maturity levels. So we have maturity levels in terms of electronic medical record or health record integration in an organization. Well, it's time to start thinking about maturity models from a safety perspective in terms of activities that are taking place. I mean, early on when we were initially implementing systems, a lot of this was an ad hoc process. Over time, it's become more of an integrated process as part of the healthcare organization. And taking those tools and those methods that were developed and applying them appropriately in a mature organization so that you have something that is a continuous process of improving the quality and safety of technologies. And there would lead to the expectation that over time, the safety of systems improves. I had someone ask me a question once at a conference. They asked, you know, are you trying to say that systems are unsafe? And I would say, no, they're not. I said, what's happened is that we've created technologies that have improved safety. They have improved things like, for example, prescribing in terms of automating processes and removing potential errors that occur. But when you have anything that's new, that changes the way we do things, we can also inadvertently introduce new types of errors. And as a result, it's a process of understanding what's happening from a conceptual perspective in terms of models and frameworks, and using methods that were used to describe these particular types of issues and to be able to quantify them. And then developing decision-making tools to help organizations identify what they need to address and when. And then also risk management processes. So over time, what happens is we create a safety science that essentially moves that button across from in the context of a safe system further along to create an increasingly more safe system. And the best example is the aviation industry. If we look at early aircraft built in the early 1900s, there were a lot of plane crashes. What happened was we started to see pilots and designers look at the aircraft itself and go, what specifically is causing these plane crashes when they occur? And they make changes to the aircraft, and it improves in safety over time, and it continues to improve in safety over time. And by the time that that we make it into today's modern aircraft industry, we have very few occasions where we have air crashes. And so any industry goes through this type of evolution in order to make the system and the industry much more safer. And what we're doing is we're continually trying to improve the safety of systems over time. And this is not a unique activity. It's an activity that's taking place around the world. And what we're seeing is that in many modern healthcare systems around the world, scientists are developing new methods, new ways of actually improving the safety of these technologies and systems. And as a result, we're getting back to that original idea of the learning organization and the learning health system, and tying that back into the quality and safety of systems, and looking at how we can sort of move that button across further and further and further as these new technologies and processes are introduced. So yeah, this continuum, you know, we have I've had some individuals over the time tell me that, you know, do you want to throw out the baby with the bathwater? And I would say to you, we don't do that. What we do is we understand how systems work, what kinds of issues we have, and we identify ways of addressing those particular issues. Because in reality, we have been doing that, and we're improving the safety of these systems and technologies so that we have safer healthcare. So I always think it's kind of fun to look back. And so we talked a little bit about the 2 Areas Human Institute of Medicine report, where, you know, the recommendation was made that we modernize healthcare, introduce technologies to improve the safety of systems based on some research. And then just a few years later, a very short time period, actually, I think it was 11 years, we saw the publication of another report called Health IT and Patient Safety, Building Safer Systems for Better Care. Normally what happens when we have dissemination of information from the research literature into practice, it takes about 20 to 21 years. This actually took place in half that time. And I'm quite proud of the fact that health informatics professionals were grabbed onto this information, and they used it in order to improve the safety of systems quickly. And they're continuing to do that as we bring in new technologies. In 2015, it was kind of interesting. The Institute of Medicine also recognized the impact this is having, the complexity of bringing all these technologies in on health professionals. And they noted that complexity is now sort of the issue that we're also dealing with, in addition to safety. It's become a safety issue in itself, because technology is actually affecting things like diagnosis and decision-making, and how we design systems. Design and implement systems influences outcomes. So with a concluding thought, we know that healthcare technologies can improve safety. We know that it's a critical attribute of health information systems, but we also need to learn from safety events. And if we're truly going to be a learning healthcare system, then learning is something that's essential, and we need to create ways of doing that. And that's been sort of the focus of the research here at the School of Health Information Science, is to make that path forward go easily. So looking at different models and frameworks, looking at what methods work and don't work, looking at key things such as identifying commonalities and things and solutions that could be achieved. And these are very important things to do, because once we have these things, then we can help organizations to implement the methodologies as part of maturity models, and we can help health professionals and health informatics professionals to effectively include this as part of their work. So, this is just my lab, some of the research that I have had funded. We're taking a lot of these methods and frameworks and applying them to different types of technologies that are being used out there. And this is just some contact information for me. And I think that's it for my presentation today. Thank you. Does anyone have any questions?